All right, everybody, we have chapter 27, which is face and neck injuries. Remember that any questions you have come up or anything that you want to review with your Q&A session, go ahead and write it down and let us know. This is in your Trauma Mod 5 module. All right, so when we talked about airway injuries way back in Mod 2, we talked about how airway and how the head is really vascular. So it is the concern is for airway compromise when you have damage to the head and the face. The other consideration that we have to worry about is brain injury or trauma to the skull itself that could transfer the energy into the brain, right? So some of these injuries are benign, but some of them can be really, really severe. And when we talk about the head and the face, we'll talk more about some of the severities with these. So we have an anatomy review, right? This is your cranium. When we talk about the cranium, the bones and plates that make up the cranium, they're connected with sutures. So when you look at the skull in the classroom, where those plates come together, they kind of come together and it looks like somebody put stitches in the bone, all right? Those are the sutures that occur with growth. So it allows growth plates to move with the brain getting bigger. When we're born, our head, our skull is actually, those sutures are not all formed, right? The plates have to be able to slide over each other to make it through the birth canal, to allow the head to make it through the birth canal. All right, lateral portions of the ear, of the head, I want you guys to pay attention to, because your temples, the temple region, this is pretty thin when all things considered with the bone and the plates. So damage to the temple region, we really have a higher index of suspicion that more injury is going on. All right, so things we talked about, the nasal bone, and then remember the end of the nose is cartilage. We have the zygoma. So some people have very pronounced zygomas. I have pronounced zygomas. This is your cheekbones. So this is the thing, like when boxers are fighting, they split open if they have really pronounced zygomas. We have the maxilla and then the mandible. The mandible is the lower jaw, and it's the only part that should articulate or move on the entire skull. So if you're getting crepitus or movement anywhere else, that's not normal. All right, so the face. Most of the face, we talk about the eye. We'll talk specifically about eye injuries, but you do need to understand that the eye is part of the face, all right? We have this orbit on here that protects the eye. So when we look back at the skull, which is the one-sided, but this round part where the eye fits in, this is called the orbit, and that's bone that helps protect the globe, and the globe is the eyeball itself, all right? So we talk about the ears. These are exposed cartilage. The ear itself can be damaged. It also can become avulsed from the head, depending on what kind of mechanisms were involved. So the avulsion of the cartilage, if you ever see somebody that has cauliflower ears, like boxers have been hit too many times, those are actually clots that have occurred into the cartilage, the vasculature, going up and feeding the cartilage itself. All right, so the face, we talked about posterior and external opening the ears, the mastoid process, that's where we chew. All right, we got this little mastoid process back here, that's where your jaw comes together. All right, so the neck has a lot of important stuff through it. When you look at the neck, all right, we know that we have the cervical spine behind us, and that the nerves that go through the cervical spine, the plexus where they come off, those control breathing, those control our diaphragmatic movements, and then movement back and forth. So we know that damage to the cervical spine is bad, right? We've already covered that. But in the anterior part of the neck, we have our trachea, and then right behind our trachea is our esophagus. And then we have these vessels, right? We have our carotid arteries, and then we have our jugular veins. So a lot of vasculature, right? That's the blood flow to and from the brain. So it's really important because we need to have that constant supply of fresh oxygenated blood to our brain. There's also some cartilage in here and some muscles that help protect it. But the front part of the neck itself is relatively unprotected. The reflex for us to put our chin down when something comes flying at us, that's a reflex because then the bony part of your chin is protecting your neck, all right? That's something that we just have that reflex to it. So when we look, all right, the cutaway of the neck, there's a lot of muscles here, and some people the muscles are really, really pronounced. Some people are not so pronounced. And then we have our trachea, that we know, and we have our thyroid cartilage at top is that big piece, and then the cricothyroid membrane that's right below it, and then you get to the cricoid cartilage. So there's a little piece of membrane here. If you want to screw around with your neck a little bit, you can feel it. And that little piece of membrane, if they were going to put a tube in somebody's neck for them to breathe, that's where they would cut. They're going to go right in the middle of that and break that membrane. We also have our thyroid that lies underneath there. So the thyroid is really vascular. It's an endocrine tissue, so it's also really important, and that can be damaged as well. All right, we know the structures of the airway, so we know that the mouth, the pharynx and oropharynx extend down, and then the trachea comes down a little bit further, right? We have the larynx where our vocal cords are at, and then we go to the trachea, and it bifurcates and goes into each lung. All right, your eyeball. So your eye is about 1 inch in diameter. If you ever got to dissect like cow eyes when you were in high school, it's pretty cool. It's really fibrous, right? The eye itself is really fibrous. So we call the eyeball itself the globe. So globe sits in an orbit, right? And the orbit itself protects about 80% of the eyeball. The different parts of the eyeball, the big ones I want you guys to pay attention to is the optic nerve. This optic nerve right here, it needs a lot of blood flow to it for it to do its job. So that's why there's a vein and arteries that go through, all right? The outer coating of our eye right here, that's your cornea, okay? We know what the pupils are because we've been checking pupillary response. We have a lens that lies behind the structures that we actually see in our eyes, and that's what allows us to focus onto the back of the retina, or back of the parts of the retina that decode information and sends it through the optic nerve. Right? The sclera is the white part of your eye. So when somebody's saying you got to see the whites of their eyes, that's the sclera. The iris is the color part of the eye, and your iris is as unique to you as your fingerprints are. All right, so in the eye, there's a jelly-like fluid in the back. It's the vitreous humor, and the aqueous humor is in the front. Aqueous humor it's kind of a cushion, and it can leak out with enough eye trauma, or you can get blood into that front part, and it looks like a little fishbowl that has this blood kind of in the middle of it. It's called hyphemia. All right, other parts. So we have the conjunctiva. This is that lining. When you pull your eyeball down or your skin down, and there's that pink part, is conjunctiva. So when somebody gets pink eye, it's conjunctivitis, right? It's inflammation or infection of the conjunctiva. Sclera, again, so that's the white of the eyes, right? The iris is the color, and then the pupil is the dark spot. And then we have our tear glands. So the tear glands, lacrimal glands, we have them up here, and then we have the nasolacrimal gland. So when you start crying, if you ever wondered why, when you start crying, your nose starts running, it's because they're connected, right? So it ends up in your sinus passages as well. Or if you say you eat something really spicy and your eyes start watering, your nose is going to start running too. All right, so we already talked about the parts of the eye. All right, the cornea is the part that's the exterior membrane. It's very painful if the cornea gets scratched. If anything gets in the cornea, we'll talk about how we deal with different types of eye injuries in a bit. Okay, pupil, we know the lens, I already showed you where the lens is behind the iris. So it focuses the images, and then there's part of the retina at the back of the eye, or the back of the globe, that kind of takes those images and converts them to information that goes through the optic nerve into the brain. Your optic nerve is actually really, really long too. And I'll show you guys a video, if I can find it, of a kid that ends up with his, ending up using a tympani mallet on his eye and pulls the eyeball out. All right, so a lot of nerve endings in the retina, and there's very vascular. Right, so injuries to the neck and face. We know the face is very vascular, the neck is very vascular. So there's some things we need to think about. With the face, all right, bleeds a lot and can potentially be an airway obstruction. The teeth can become dislodged, also become a potential airway obstruction. We deal with dislodged teeth as if we were dealing with an amputated part, right? The larynx is not very well protected, and these blood vessels here are not very well protected. So we know that if an arterial damage to the carotid artery, we know it's going to squirt blood, okay? What we don't think about as much is when you end up with a jugular issue, so the jugular vein is damaged or open. Veins work on valves that shift the blood flow up to the next level. These are such large veins that air can actually get pulled in while the veins are moving blood through if it's open. And it's going to bleed a lot, but air can get pulled back into it, and you end up with an air embolus that's going straight into the vena cava. All right, so swelling, especially swelling of the neck down here, that can cause stridorous respirations. And when you swell in the neck, it ends up potentially cutting off the blood or the air supply, right? Pushing pressure on the trachea. Or if it's swelling on the sides, sometimes you get big hematomas, patients with really big hematomas because they're bleeding under the surface of the skin. I can't tourniquet their neck, but that hematoma itself can actually cause an airway obstruction too. So here is a picture. What I think has is a skin tear because the skin's very thin. Bumped her head. She ended up with a nice little hematoma underneath it, which is just that nice juicy tomato of blood underneath the surface of the skin. And it broke, and it kind of shows you how vascular that head is when that blood collects underneath it. Dental injuries. So mandible injuries, all right? Mandible injuries to the top can, if they take a direct blow to the face, can be very common. Sometimes when we've got something flying in our face, we actually open our jaw a little bit, and it protects us. Again, that's one of those reflex things. With blunt force injury, we can end up with the maxillary, that part moves fractured. And when we're articulating or we're feeling, right, for crepitus or step-offs, you feel something push one way or the other, that's not a normal finding. Right, that's why it's important when we do our trauma assessment, we're touching everything. Across the zygomas, I start down the nose, across the zygomas, and down the jawline, right? It's also really important that we're looking for clues like blood in the nose. With a trauma to the head, especially a lot of force, blood in the nose is not uncommon, right? We know that people can get bloody noses from being hit in the face. But if there was enough force that ended up cracking or fracturing the skull, you can end up with cerebral spinal fluid coming out of it. Sorry. My dogs barking everything. All right, so cerebral spinal fluid can be mixed with that blood. Same thing in the ears. When we go down and do our trauma assessment, we're going to start practicing this. You're going to make sure you look in the ears and also checking the eyes, because the ears can end up with blood draining out or fluid draining out, especially after blunt force trauma. Dislodged teeth. So my least favorite thing in the world is teeth. Dislodged teeth with trauma. My kids' teeth, like when they grow older and their teeth start falling out, those are all things that are just glorious to deal with. But when teeth are dislodged, they become possible airway obstruction, all right? But they also, we treat them like an amputated part. So you keep them moist, but not wet, all right? And we put it with ice, but not on ice. Your book talks about using milk. I don't know, but I don't carry milk around with me in a hot car all day long, not carrying milk around in an ambulance, and I will get fired if I stop at the store and try and buy some. So we treat it just like we would any other amputated part. Keep it in a moist piece of gauze, and then put it with your instant ice pack, but not directly on ice. Instant ice packs don't get cold enough to cause damage to it. The reality is, in this day and age, they rarely reimplant the teeth expecting them to grow back. They might use them as a placeholder if they can reimplant them if they're in whole, until they get to an orthopedic or a dental surgeon. But for the most part, teeth that come out are teeth that come out. Okay, so soft tissue injuries, again, how we're going to treat them, you're using your ABCs. So remember, what makes a priority patient is if they have a change in their level of consciousness, because your primary survey starts, actually, if they have a poor general impression, primary survey starts with general impression. So if you have a poor general impression of them, the mechanism looks bad, all right, your little spidey sense in the back says, something's not right. Poor general impression, they're automatically a priority patient. We still finish our primary, but again, that makes them that priority patient. If they have a change in their level of consciousness from the baseline, if they have anything wrong with their A, B, C, right, airway, breathing, circulation, disability, something that could cause long-term disability like teeth being dislodged, potentially head injuries, right? Or if there's an environmental exposure or hazard, we want to make sure that they are a priority patient at that point, okay? So make sure you're assessing and treating your ABCs, making sure you have airway clear, controlling the bleeding, right? have your suction ready. Anytime there's a facial injury that's bleeding, you want to make sure that you have your suction ready. And then it talks about avoid moving the neck in the patients with spinal or potential spinal injuries. We follow those SMR guidelines. Now remember, we teach you in class the highest level of spinal immobilization, and then you apply that with common sense and guidelines using your SMRs. SMRs are found in online homework in D2L. You can find the videos and watch those 5 videos. So we use those guidelines to determine how we're going to account for the potential of the spinal injury. All right, direct pressure for most bleeding stops it, even bleeding on the face, okay? If it's a skull fracture, you don't want to push really hard, or if there's a potential of a skull fracture. And especially if you push down, there's crepitus there, right? Don't feel it again, you know that there's potential of a fracture. But be careful when you're applying gauze. Same thing with a nosebleed. You don't want to pack the nose. That's something we don't do, all right? But when they have a nosebleed, make sure that you're collecting the blood, but you're not sitting there trying to completely stop it. As in a medical patient with nosebleeds or like a geriatric patient, yeah, we're going to do the pitch lean forward. I'm going to have them put a gauze here and lean forward. I have them lean forward because I don't want them swallowing the blood, because again, that's an airway issue. When blood and stomach acid mix and enough of it gets together, there's a return policy. So I don't want them puking whenever I got other things that are potential airway issues. All right, it's actually the only time I'm okay with somebody spitting is I'll give them a vomit bag and they can spit the blood into it. All right, let's see what else. When you're in class, you should practice putting dressings, soft dressings on head injuries. It's more difficult than you would think. You can't wrap all the way around the neck. It's a bad idea, right? You don't want the jaw really tight. So try practicing that because there is a challenge to it. All right, injuries that didn't break the skin, obviously ice. We know that ice is a very good thing to help with the hematomas and the swelling. And then look inside the mouth. So what I do was somebody's taking, when my kids were playing baseball, it was always a baseball to the face. Not my kids, but somebody inevitably took a baseball to the face. So I would have them, I would look in their mouth, I visualize in their mouth, see if there's any obstructions or what the bleeding is going on. And then I would have them run their tongue along the backside of their teeth, all right? See if anything's loose. And then have them just close their mouth and bite down and see if anything feels out of their normal alignment. That's how I assess the mouth with mouth injuries, okay? Most people can hold their own direct pressure with facial injuries if their mental status is appropriate. The exception being little kids, because when little kids cry, they do the thing, and I don't want that piece of gauze being sucked back into their airway. All right, so avulsed skin, pieces of avulsed skin, the ear is commonly avulsed. You want to see an ear injury, watch Mike Tyson, Evander Holyfield fight, the old one, and you'll see Mike Tyson rip Evander Holyfield's ear partially the way off. It's not uncommon. So we need to put a dressing on that because it's going to bleed pretty profusely, right? And we want to make sure we're padding enough underneath it because your ears don't normally sit flat against your head, all right? So make sure that you're having it padding when you're wrapping appropriately. If the piece of tissue completely comes off, again, we wrap it with a sterile dressing and put it in a plastic bag with ice, not on ice, okay? My rule of thumb, this is Laura's rule of thumb. If it's normally moist, keep it moist. If it's normally dry, keep it dry. So if the tissue visible is outside the head or outside of the ear, it's normally moist. No, it's normally dry. We keep it dry. If it's something from inside the mouth, I've had people bite off the end of their tongue, and we found that there's a piece of tongue they're holding when we get there, bleeding profusely. Put it in there. It's normally moist. We keep it moist. All right, that's just my rule of thumb. All right, in injuries to the eyes, with sports and also with certain types of industrial settings, injuries to the eyes can be common. That's why we're supposed to wear eye protection, including firefighting. But we want to make sure that we're assessing appropriately and have a plan in place what you're going to do if somebody has an eye injury. So if that retina becomes detached, they can end up having blindness, right? If the optic nerve is not fed the fresh blood that it needs, they can become blind, okay? So we're always assessing the eyes. Are they equal, round, reactive, and light? When somebody has an eye injury, one of the things I had check, unless there's something grossly protruding out, all right, we don't want to have something just poking straight out from our eye and have it move around. But your eyes move together, all right, where it's called sympathetic eye movement. So one of the things, are they tracking you with their eyes? you don't want to rub in there and pick out if there's sand or potential of having metal in there. People who scratch the cornea can also leave the metal or leave whatever's in there behind. We don't go picking stuff out. It's just like having a foreign body, stuck in. We just stabilize it. Try not to make it worse, right? When somebody has an eye injury, be it sand in their eyes, be it pieces of metal that they suspect because they were cutting, metal and not wearing appropriate eye protection, or a pencil sticking out of their eye. We want to make sure that we are covering the injured eye somehow, all right? And I'll show you one of the things I had a student teach me about 10 years ago. Cover the injured eye, and then we also cover the uninjured eye because of that sympathetic eye movement. Two things. One, you've just taken somebody's vision away from them completely, and they've already had their vision, it's a scary thing to lose vision in one eye. So be aware of that. Make sure you're treating them appropriately, telling them what you're going to do before you do it, all right? We also don't want to put pressure on the injured eye if there's something caught inside it. So you'll see in class we could do the donut roll with a piece of Curlex or roller gauze. There's a donut roll we could do. Or I can show you something else that's cool to address an eye injury, and we'll get to it in just a second. So let me grab it. Okay, I got my cool little thing that I'm going to show you here when we talk about treating of eye injuries. But make sure that when somebody has an eye injury, you are just not putting pressure on it, you're treating appropriately. Same thing if they've had trauma to the head and you see that hyphemia. There's some good pictures of it in your book. Kind of looks like fish bowl that has blood halfway through it. Also keep in mind, so one of the problems is you're taking away their sight when we're dealing with emergency treatment for eye injuries. It also can cause a person to be incredibly nauseous with their vision distorted. So that brings up another potential airway issue, right? Foreign objects in the eyes, so they can leave scratches behind. Corneal abrasions are really, really painful, or they could end up being stuck in the eye still. So that's something that they deal with at the hospital. For us, in emergency care, we irrigate the eyes. So we can use a couple different methods. There's some in your books. I don't like to splash the water up, especially not for chemicals in the eyes, but in general, I just don't want it because whatever they're had contaminated has the potential of going back up in their eye. When we irrigate an eye, right, so when we want to flush it out, we flush away from the unaffected eye because you don't want whenever you're flushing out to roll into the other eye. If it's both eyes, you can flush down from the nose down, all right? And in class, again, ask your TAs and your instructor to set up the eye irrigation using IV tubing and a nasal cannula. It's a cool little MacGyver trick that we can use to irrigate the eyes and put it right over the bridge of the nose. It irrigates the eyes out. We also have this thing called a Morgan lens. It's like a hard contact lens that has tubing on it, and you hook it up to an IV bag, and it sits in there and irrigates the eyes. Again, you want to make sure the water is going away. That's only used with medical direction. Not every agency or region has direction to use the Morgan lens. It also is incredibly painful to irrigate somebody's eye. You really have to pry their eye open. I'd say pry is a bad idea, but pull their eye open, right? And you're splashing water in. It's room temperature water or solution, not water, but saline solution hitting their eye. It's not very comfortable, especially not if it's a continuous thing, all right? So we can try irrigating the eyes for a few minutes. Your book has the different numbers for the different types of acid versus a base. But foreign objects in the eye, we can try an irrigation for it. If it's something literally just poking out of the eye, like a pencil or a piece of lead, things that kids do in school, we stabilize the object and we prepare them for transport. So because I don't have an actual BVM, a pediatric BVM in my house, which is kind of weird, I thought maybe I did, but we have face masks. So you're gonna have to use your imagination a little bit here, all right? So you know how in the BVMs, they have the little ones for child, and then they have the baby ones for infant, all right? So a face mask for a BVM has the little port where it connects to the BVM itself, and then it's cushioned all the way around it. So if I take a small pediatric baby one, it'll go right over my eye just perfectly, right? And I can use that as my dressing for the eye. I need to remember to cover the other eye as well. The other kind of interesting thing is if I have to stabilize something that's really that long in the eye, there's a potential it'll fit through that port where it hooks into the BVM. So using the things you have available to you, making them MacGyver to the situation. I can't, take credit for that. That was a student that came up with that. We also will show you the donut roll and other types of things that you can use. All right, burns to the eye. So the biggest thing is stop the further burning. Chemicals, so alkalines and acids. Alkalines are more detrimental to tissue than acid is. If it's a dry chemical, you want to brush off as much as you can, because if it's reactive to water, it's going to react in their eye. All right, liquid chemicals splashed in the eye, we can irrigate. So here's an example. This one's using the nasal cannula up here at the top. This is an emergency eye wash station. See how they're holding their eyes open each time. We're using irrigation saline right here, and then this is the splash up. It looks like he's ready to just dunk her head in the basin. I don't have a basin, nor do I have that much water in my ambulance, but we need to use some common sense with those things. Other things to deal with the eyes are thermal burns. Your eyelids are very, very thin, so somebody who has burns, we worry about burns to the airway, which is dealt with in soft tissue, all right? But the eye, the eye coverings, right? So when you close your eyes, your eyelids, they can actually become burned off, all right? And then we're also thinking about singed hair and airway issues. Light burns, so from lasers, from looking at the sun, people who are welding without the proper eye protection, they just look away, that still has flashes. That can cause a lot of damage, irritate the conjunctivi a lot, and then they end up having like this swelling and they can lose their vision because of it. Laceration, so this is something that has to have precise intervention. You'll have to have an ophthalmologist go in, surgical ophthalmologist, and restore the tissue together. It's a big deal that we get them to an appropriate facility that does have ophthalmology on staff, so that they're not waiting additional time for ophthalmology to come. My rule of thumb, anything freaky weird, they're going to a trauma center. Anything that might need a specialist, I'm taking them to the trauma center. Those are for the patient's best outcomes. Those are things I think about. I will show you the video here with the eyeball that's going to be displaced from the socket and how they managed it. So let me pull that up. Okay, so up here in this YouTube video I pulled up, I want you guys to pay attention to the top right-hand kid, all right? You're gonna watch what happens. So you see his eyeball literally fell out, and it's the optic nerve that's holding it in place. So good for him for not yanking on it. Be a reflex for a lot of people, right? So now his eyeball's hanging out here because he hit it with his tympani mallet, and his eye, if it's still showing anything to it, it's probably looking at the ground, and then the other eye is looking around. So we weren't built to look two different directions. We're not lizards. So once the adrenaline kind of calms down on him, he's going to start getting really dizzy, really lightheaded, and possibly vomit. The other thing I want you guys to think about is this is a really long nerve, all right? So there's a lot of things that we have to take care of. The eyeball and the nerve here, the optic nerve, normally moist. Not talking wet, moist. So we want to make sure that we are dressing it with a moist, sterile dressing. And then this is a really good time to use that pocket face mask, all right, and kind of hold it in that, and then wrap both eyes to get them to the hospital. So I'll let you see this. So the whole thing is called Drummer Boy Turns into Sideshow Bob. You want to watch the rest of it. We're not going to watch the rest of it. All right. So we talked about lacerations. Make sure everything else is good. Okay. Blunt trauma to the eye, you just kind of saw the trauma, right, with the tympani mallet. But the other thing, again, your eye is 80% protected by your orbit. So hyphemia, that's where it bleeds because your eye is very vascular. So bleeding comes in and it looks like just a little fishbowl of blood, right, in front of the iris. And then orbital fractures and retinal detachment. So if somebody has retinal detachment, they might start seeing spots, or they might have no vision in that eye whatsoever. All right, eye injuries and head injuries. So make sure you're having that mechanism in your head. How much force? Remember that different parts of the different forces enacted on the body during traumatic injury. It doesn't just stop when it hits the skull. That energy is transferred to the tissue underneath it, which happens to be the brain. So you want to make sure that you're paying attention and that you're doing an assessment and reassessing your patient regularly, because they have the potential of having a brain injury underneath this. Blast injuries in the face, obviously we worry about facial issues, airway issues, but the brain itself, right, needs to be protected. So if somebody's thrown back and their head is cracked or fractured, that's something we have to think about. The other thing is the inner ear. So the inner ear is very, very sensitive to pressure changes, and with the blast wave, that pressure change or that pressure wave goes out and it can damage and burst the eardrums. Eardrums, when they burst, are incredibly painful as well. So the patient's going to be in excruciating pain if they are conscious. Make sure you're doing a really good assessment on them though. Your ABCs, all right? We're doing your secondary assessment. You're checking the ears, you're checking the nose, you're looking at the pupils, seeing, debris can get in the eyes as well from a blast, depending on how close they were to it. Contact lenses in eyes. So we don't remove contact lenses. I can tell you from, I used to wear contacts, but also from years of doing this and having irrigated various people's eyes out. In the process of irrigating their eye, the contacts usually fall out, all right? There are hard lenses and they have to use the suction cup thingy to pull them out. I think Brandy's the only one I know that I've known for, that I have even heard of in the last 15 years having hard contacts in. So irrigating the eyes is all it takes to get the contacts out if they're in there. Be careful though with chemical exposures, because people who've had chemicals in the eyes, now when we're irrigated, the contact comes out with the chemical, that's fine. But you can actually end up with a corneal detachment where the contact was if chemical gets underneath it, which is why they tell you in chemistry classes to wear glasses, not contacts to class, because the fumes can get underneath there and cause a lot of damage. Here's an example of the suction cups. Soft contact lenses. I don't like fishing around in anybody's eyes, again, so irrigation is my way to go. All right, nosebleeds. Nosebleeds are fairly common. So we call it epistasis. Digital trauma is the most common cause of nosebleeds, and it's usually young boys and old men, or young children and old men. And digital trauma means finger up the nose, okay? So anterior nosebleeds, that's right here, the area of the septum, they bleed slowly. Posterior nosebleeds will cause a lot of blood to come out, and it'll go back in the throat. Most people do the old thing where they tip their head back, right? And it just rolls the blood down the throat. It doesn't matter where the position of that nosebleed is, okay? I can't stick my finger all the way up there and put pressure on it. The only thing I can do, and the only thing the patient should be doing, is pinching their nose and leading forward. Spit into a bag the blood so that they don't end up mixing it with the stomach acid and throwing up. You're basically encouraging a giant blood booger clot to build. When the nosebleed subsides and they take their fingers off, don't let them blow their nose, because they blow their nose, the first thing that's going to come out is that clot. Happens a lot to people that are on blood thinners. And when I first went to Green Valley, I was like, why are we calling 911 for nosebleeds? I went in there and it looked like The Exorcist was all over the place, because the blood thinners made them bleed so profusely that they couldn't stop the nosebleed on their own. Right? Blunt force trauma, again, fractures, soft tissue injuries, head and neck injuries, punches to the face. I don't like working standbys for fighting for MMA or boxing. I'll watch it, but I don't like working on it because I think, oh my God, the head just got whipped back. Their nose is bleeding. They've got double black eyes. Those are things we're looking for, when we think about head fractures. So it just kind of makes me a little bit more paranoid than I want to be. Other issues that we think about when we talk about head injuries. When somebody's got a skull fracture, there is the potential of them collecting blood underneath their eyes, right? It's usually an older skull fracture, meaning not old like years, but it happened several hours to a day before. We call it raccoon eyes underneath, okay? The other thing that can happen, depending on where the fracture is, they can get this battle sign. It looks like bruising behind their ears, and that's where blood's collecting behind their ears under the skin, and that's called battle sign. Both of those are indicators that that patient has a skull fracture. And when you guys deal with head trauma, we'll deal with that a little more. All right, so cerebral spinal fluid can escape through the nose, all right, from the base of it when somebody has a skull fracture, and depending on the type of skull fracture. they're more likely to have the CSF escape through the nose, right? Especially if they've fractured the bones behind. So injuries to the ear, we talked about it. 3 parts. You've got your external ear, that's the part we all see, middle ear, and the inner ear. We actually have our balance center is in the ear, the inner ear. Tympanic membrane is how we hear. When somebody's eardrum ruptures, there's a rupture of the tympanic membrane. This is also what they put tubes, they'll put it through here, and they surgically implant tubes into kids' ears to allow the fluid to drain out if they're getting infections a lot. We actually, our center of balance is in our ears. So that's something to think about too. All right, I talked about the avulsions of the ears already. I was ahead of myself. Tympanic membrane ruptures, again, blast injuries, people that are diving, people that are going to altitude, clearing their nose. It's incredibly painful. When somebody has a tympanic membrane rupture, they can actually get a lot of swelling on their side of their face too. All right, foreign bodies in the ear. It is a thing, it happens, hopefully with children. I also have had foreign bodies in the nose that we've had to go to. Again, hopefully with children, right? But foreign bodies in the ear. My friend her son had a Lego stuck in his ear, one of those little tiny square ones that have the sharp edges, and they had to go in and surgically remove it because he jammed that thing far enough down they couldn't get it out. And then again, clear fluid draining from the ear could be a sign of a head injury. That could be cerebrospinal fluid. There's actually a thing you can do, and it's not really super reliable, but it's just like, oh, I've got all this free time, right? It's just got a head injury, bleeding everywhere, but I'm going to do this. You get a piece of gauze. When they are bleeding from their nose or from their ears, you take that, collect some blood on the gauze, set it aside, and if it gets a halo appearance to it, that's the cerebrospinal fluid on the side, the exterior part of it. It's called a positive halo test, and that's something that's a clue, right? We're collecting clues that we're sending to the hospital, or relaying to the hospital that you had a positive halo test, the blood from either the nose or the ears. Facial fractures, right? If there is no serious bleeding, they tend not to be emergencies, but remember that force that can be transferred underneath or below. That's something we definitely need to consider. With facial fractures, depending on what it is, they'll have to have plastic surgery to repair it. I've seen plastic surgery extend out, a month or two, depending on if they have to do reconstructive surgery with it. People who have shot themselves in the face or the mouth, or been shot in the face and the mouth. Swelling is extensive, though, with facial injuries and facial fractures. Any injury to the face, you have the swelling can be massive amounts of swelling. So we want to make sure we're mitigating that while we have them. And then dental injuries, again, it's very traumatic to the patient. If I'm the provider, it's going to be incredibly traumatic to me, right? Direct pressure, suctioning. They can hold their own pressure. I would say don't spend a lot of time on scene looking for teeth that have fallen out. If you've got a lot of bleeding going on in the mouth, that patient's priority. So I had to bust out his teeth in the gravel. I'm like, we're never going to find your teeth in here. And then again, that's part of your documentation that you were, successful or unsuccessful locating what you thought was the teeth. So suctioning, a lot of times patients, if they're conscious and it's isolated to their mouth, they can hold their own suction. So that is a little bit more comfortable for them too. So you're not like opening their mouth and suctioning their mouth out. Injuries to the cheek. So you get avulsed parts of the cheek, something protruding through the cheek, right? Make sure we're stabilizing it. Most people though, if they have something that goes through their cheek, they tend to pull it out. As far as actually a lot of impaled objects, if they can remove it, they tend to do that before you get there. It is not uncommon for somebody to bite down on their cheek really hard and avulse pretty significantly. Same thing, kids jumping in the pool or anybody jumping in the pool, the chin, or where you take the teeth and they put the teeth through the lip, also very common. So make sure that I would have them hold their own pressure if they're old enough to do it, have suction available, and then something for them to spit into so they're not swallowing the blood. All right, neck injury. All right, injuries to the neck. So we have a variety of different types of injuries that can occur. In Arizona, barbed wire, necks and barbed wire seem to come together in various ways. Sorry, this guy's recording nuts again. So when somebody has barbed wire that hits their neck, right, it can cause a clothesline type injuries. When somebody is clotheslined with a fist or a baseball bat, that's blunt trauma, and it causes damage to the larynx or the trachea. It doesn't necessarily have to be an open injury, but they would be hoarse to speak, right? A lot of swelling. They might have that stridorous respirations. And then they also get subcutaneous emphysema if air is leaking out from those structures. So you feel under the jaw, right? Because that's where air is going to try and go to the highest point. If it feels like you've got Rice Krispie treats in a plastic baggie and you're pushing on it, that's called subcutaneous emphysema. It means air is not where it should be. And you also get under the clavicles too, especially if there's damage to the chest. So the trachea, right? We have that's very vulnerable, and then those blood vessels can become open. I've seen somebody where they had a clean cut to the neck, didn't damage any of those blood vessels. It's actually really cool. You could see the muscles and the blood vessels themselves. And the trachea was open and dislodged. It was from the strap. Somebody had an improper placement of a strap on a motorcycle helmet, and it cut right through their neck. It was real easy to intubate them. Penetrating injuries, again, you can bleed out very quickly from the neck. We can't put pressure on both sides of the neck at the same time. Cuts off the blood flow to the head. So you do pressure above and below, hoping that it's only on one side, right? And when we're putting a dressing onto a neck bleed, somebody that's bleeding from the neck, you want to use an occlusive dressing. Because remember how I told you that air can enter back into the venous system. So we know that arterial bleeding needs pressure, but we want to use an occlusive dressing as well. Bleeding to the neck is incredibly difficult to control, especially if it's bilateral. All right, laryngeal injuries again, steering wheel, somebody hits something hard, bicycles if their kids are small, or they're on those little trick bikes that the handlebars are up higher from the seat. ATV accidents through barbed wire, we see that. So it can cause that laryngeal. You have them try and speak and they have a hard time speaking. You see a lot of contusion, swelling. Sometimes people, when they're choked, can cause the laryngeal issues, or if they were hanging or near hanging, you'll see the ligature marks. That's what that's called when you have bruising or marking around the neck, and they will have a hard time speaking, and we worry about the fractures to the larynx. All right, so there are only 2 times we remove an foreign object or impaled object from a person. All right, one time would be if it is covering or causing an airway obstruction. All right. The second time is if it's causing an obstruction to doing CPR. So if it's where your hands and you go for CPR. Does not mean that you can just remove that object if they're not in cardiac arrest and you don't need to put your hands there. You wait, because it can be tamponading off or pinching off the blood flow and actually controlling bleeding by being there. Up at the larynx, again, in the larynx, if they can have a patent airway, we want to just keep them talking, suctioning as best we can, all right? All right, so we already talked about signs and symptoms of laryngeal injuries. Again, make sure you're checking for that subcutaneous emphysema. If you ever get the chance to feel it, it's really cool. Get consent from your patient. But being able to feel subcutaneous emphysema is something not everybody gets to do. So that is the end of this chapter. Make sure that things you want to review, you're talking to your instructor during Q&A. You want to see the eye irrigation with the nasal cannula, you can ask your instructor, your tutors to do that. That you're doing your D2L quizzes, asking questions if you need any clarification on the answers and why the answer is the answer on it. And you're doing your JP Learning quizzes, as well as reading the chapter. Let us know if you need help with anything. At this point, we're going to end this lecture.